Good evening, everyone. I am Dr. Nisar Shah, MCH Surgical Oncology, passed from GCRI and currently working at SSGH Vadodara. In recent advance, I would like to discuss something about SLNB as possible revolution in head and neck oncology. It's from blind dissection to a targeted strategy. Starting with the epidemiology of head and neck cancer, we all know it's the most common cancer in the India with an Gujarat as an epicenter. It's the 7th most common cancer worldwide with more than 8 lakh new cases reported annually. In these importance of the proper nodal staging for head and neck cancer, as we know, the cervical lymph node metastasis is the strongest predictor of the survival, with 5-year survival drops by more than 50% with nodal involvement, and accurate staging critical to guide the neck dissection, radiation for field planning and prognostication, while conventional imaging often misses micrometastasis, that is the lacuna. As we can see in these chart, as overall survival, DFS and DSS all decreases with positive sentinel lymph nodes, and relapses increases by more than 30%. So exactly what is the management of neck in early head and neck malignancy? By means of early head and neck, that is T1, T2 and N0. There are two poles, one is the observation and one is the SND. SLNB is giving one path between both the poles. If SLNB is negative, we can keep the patient on observation, and if positive, we can do single stage SND or completion neck dissection in the second sitting. This is the chart from the NCCN, which also mentioned as a SLNB as a alternative to the SND in early head and neck cancers. So what is the sentinel lymph node biopsy? By definition, it's a procedure to identify, remove and analyze the first draining lymph nodes from a primary tumor site. Its goal should to detect occult metastasis in the clinical node negative patients, and its concept is same as we are using in breast cancer, that is tumor drains first to 1 to 3 sentinel nodes. If these are clear, rest of the neck is unlikely involved. How SLNB is evaluated in the head and neck cancers? So in early 2000s, it was in experimental phase. In 2003, the first multi-center study was published. In 2010, it was validated for early head and neck cancers. And in 2020, it is included in NCCN and ESMO guidelines. So what is the current status? Current status is it is accepted alternative to elective neck dissection in clinical T1 early head and neck oral cancers. And it is also used for cutaneous head and neck melanoma and non-melanoma cancers. What are the common sentinel node location by the site? As we all know, for oral cavity, tongue and floor of mouth, it's level 1 to 3 lymph nodes. For oropharynx, level 2, 3 and sometimes retropharyngeal nodes. For cutaneous lip, cheek and ear, it's a preauricular, parotid and level 1 to 3 nodes. And for scalp melanoma, it's occipital, preauricular and level 5 lymph nodes. So we will discuss some advantages of the SLNB. SLNB can avoid unnecessary dissection in up to 70 to 80% of early head and neck cancers, that is T1, T2 and clinically node negative cases. It's minimally invasive, so small incision and less scarring. Lower morbidity, so accessory nerve injury and less shoulder dysfunction. Potentially it lessens the morbidity of the large surgical resection. It guides the treatment approaches, detects earlier stage micrometastasis and thus guides the prognosis. But there are some challenges for SLNB in head and neck cancers, as there is a high density of lymph node in head and neck region that limits the SLNB detection. Close proximity to the primary tumor, that gives the shine through effect. Complex lymphatic pathways are specifically present in the head and neck region. It's contraindicated in female and breastfeeding females. Radiation exposure to the staff and completion neck dissection has to be carried out if SLNB is positive in final HPR. Uh, there are some challenges due to the complex lymphatics, lymphatics crosses midline. Multiple sentinel nodes are possible in head and neck region. Difficulty in assessing retropharyngeal nodes. Certain tumors may have the skip metastasis. First draining node may differ from the expected location, and tumor size can alter the lymphatics. So all these high variability will demand pre-op imaging in the form of SPECT CT, intraoperative expertise, as well as experienced pathologist. This is one study which shows the topographical distribution of the sentinel nodes and metastasis from early head and neck cancers, which also mentioned that 15% of the patient with occult metastasis would have missed by conservative neck dissection only in early cases, because they what they shown that 15% patient have sentinel lymph nodes in level 4 and level 5 group. So that is not removed in SOHND. This is one another good study from the Naples, Italy, who have shared their 20 years of experience in the SLNB in head and neck early cases. They have included total 122 patients in which they have done SLNB, and they also concluded that false negative rate of SLNB in head and neck is less than 10% in expertise cases. And in their paper also they have noted that almost 18% of the patient have level 4 and level 5 sentinel lymph nodes. So only SOHND would have missed that all lymph nodes. This is one another study, and this is a phase 3 study, which is a randomized multicenter and non-inferiority trial to show the sentinel lymph node navigation is equivalent to elective neck dissection in early oral cancer. Here they did 275 patients randomization in 2 groups, one assigned to elective surgery and other to undergo SLNB nodes. And its result was SLNB arm has shown improved constant Molle shoulder score, better pain, tactile sensation, better scar appearance, trends towards less edema, non-inferior to the SND in terms of OS, DFS and DSS, and it can guide resection methods in T2 tongue cancers, which is WLE versus compartmental, which can be decided based on SLNB result. So this is the Kaplan-Meier curve, which also showed that DFS and OS was similar in both the arm, though DSS was slightly higher in SND group, but it was insignificant. This is the recent advanced study. This is remote access SLNB in early head and neck cancers. With more and more intraoral surgeries for early disease, remote access SLNB will provide scarless face and neck with best aesthetic results. Here what they have done, they have used dual dye technique. One day before the surgery, they have inserted a technetium 99 dye, and then they did the SPECT study, identified the sentinel nodes, and on the day of surgery, with the help of gamma probe, they surface marking was done, and then they inject Orogreen, and with the help of ICG, they identified the nodes. But here the catch is what they have kept incision is retroauricular in the hairline region. So there is no scar on the face or neck. These are some indication and contraindication as we have mentioned. So what are the hurdles for SLNB to include in day-to-day life? Though lots of theoretical advantages of SLNB, practical application in head and neck is a bit difficult in our setup. Routine SPECT CT adds huge financial burden with little effect. And experienced surgeon as well as pathologist is a necessity. Till now, no study to show the observation is acceptable mode in SLNB positive by IHC. So completion surgery is the must, and the patient has to undergo a second surgery. And after 1 year, there is no difference in quality of life between SLN group and END group. So to conclude, SLNB should be one option in our armamentarium while treating early head and neck cancers. A remote access SLNB is a good option when aesthetics is a priority, and SLNB should be used as a de-escalating as well as navigating technique to reduce the recurrence rate. Thank you.
Good evening, everyone. I am Dr. Parigna Trivedi, consultant radiation oncologist at Shelby Hospital, and I'm excited to talk about recent advances in radiation therapy. And the radiation fanatic in me, of course, wanted to talk about proton therapy, MRI LINAC, time to adapt with the MRI LINAC, or like delivering hundreds of grays in fractions of seconds, or like how AI might be just be the future of it. But today, not carried away by my temptations, I'm going to focus this talk on the clinical implementations which we can do it from tomorrow, things that are precise, clear, and in the data. So with all this, I am going to naturally start with something that keeps us busy here every day, that is oral cavity cancer. It's a global prevalent disease with a standard protocol of surgery followed by post-operative RT. And with this in head, Karki et al. Had evaluated a data where they tried to investigate the oncological outcomes and late toxicities for post-operative oral cavity if they would eliminate the elective nodal radiation. So it was a multicentric retrospective cohort of data with a good number of patients of 264, and they were divided into post-op RTT, that was when only the tumor bed was irradiated, and TN, when the tumor bed plus elective nodes were irradiated, with the end point to learn about the regional control, local control, overall survival, and late toxicities. The inclusions criteria were very simple: unilateral or a bilaterally dissected neck with no lymph node mets. They had prescribed the dose based on the margin status, and an elective nodal dose was kept to 46 gray in 23 fractions, which was mostly delivered in an SIB method. To see this, there was a, for the tumor distribution, we could see that most of the patients were floor of the mouth and tongue, while after that it was from alveolar process, RMT and buccal mucosa. Equally well balanced patient in the staging, like for T1, T2 and T3, T4, but still we could see like a majority of them came from T3, T4 category. Along with this, I want to emphasize on the distribution of lymph nodes they had removed, and it was 17, more than 17. Most of the patients fall in the, under the group of more than 17. Why I want to talk about is because in the regional control, there was none other factor which was of significant relevance except for the ipsilateral lymph node yield. In the whole group, there were just 9 regional recurrences, 4 in the post-op RTT group, while 5 in the post-op RTTN group. 5 of them were infield recurrences, and 1 where we had an on-presentation distant met, while the rest of were just the regional recurrences. Local control was seen where they saw 23 patients had local recurrences, again 10 in the post-op RTT group and 13 in the post-op RTTN group. And then this did not reach any statistical significance. So overall survival, the unadjusted 5-year overall survival was 80% versus 78% for both the groups, and again it was not statistically significant to irradiate the neck. Talking about the late-term toxicities, it was seen for grade 2 and grade 3 xerostomia. The only factor that remained significant predictor was the irradiation of the neck, while the total dose, even that also lost the statistical significance. Talking about grade 3 and grade 3 dysphagia, irradiation of the neck along with the PT3, T3 and T4 status remained the significant predictors on how the toxicity is presented. So from this, it was a large multicentric data from a real world evidence, giving us a key insight to say that there was no added regional control benefit when the elective nodal irradiation was done, while we were putting the patient under the toxicity burden of xerostomia and dysphagia, which was higher. 12 centers with 264 patients coming from a 5-year outcome with a uniform protocol. So with this, we can consider omitting elective nodal radiation with seeing all the local pathologies and considering it in the picture. while what we will do is reduce the toxicity, late toxicity, improve the quality of life, and we will give a greater ability to retreat or salvage the neck if needed. We will keep a caution on the nodal yield, of course, and individualize the treatment based on the margin status, tumor aggressiveness, and the subsites. From this, we can say that it challenges us to rethink the balance between the disease control and toxicity, and it can, of course, challenge the fact that less may truly be more. Given this and said this, another question that may arise to the mind is, when we say the less is more, can there be any other form we can radiate? So this is where specially fractionated radiotherapy comes into play. So it is a philosophy change where we are saying that till now we were doing what was, we were variating our dose based on the time. So every day we will give small fractions daily. And now what we are saying is we are going to be modulating, specially modulating the treatment based on clusters of hot spots and clusters of cold spots. So basically, now we are saying we will variate the dose based on the distance. And not only we are just changing or asking for a philosophy reshift, we are saying that we are going to exploit the other radiobiologies that comes and plays with it, saying that we will have a bystander effect in the valley area, that is a low dose area, with an abscorbal effects coming into play. Other than that, it will, we are saying that the growth and the proliferation of the vascularization might come to an normalization. So it will again increase the permeability, and the drug delivery might be improved with this. Not only this, we are also saying that it will do an immune modulation by targeting a pathway, that is CGAS pathway, and it will introduce more of interference, and hence by it will drive in the immune response better. With all this said and done, this is a modulation technique. We create peaks and valleys. This was when the 2D era, we had a grid system which was fixed to the head of the linear accelerators. And now with high, we have technologies where we can focus and create a lattice system, which is a 3D form of the grid system. And from this, I want to address a paper by Nina A. Mayer et al., where they had done a survey of clinical practice for the specially fractionated radiotherapy. The aim was simple, to understand the SFRT selected, planned, and integrated with systemic therapies. And what they did was, there was a 60 question tailored questionnaire where they had given to the radiation oncologist, physicist, and biologist, and then it was again put to permutation and stats. The results were very interesting. What we saw was 72.7% of the physician already considered it as a standard, and they did not feel the need to put it into an ethical committee or an IRB approval before implementing the system. 52.9% were actively practicing SFRT, while almost 12% were considering to inculcate in 1 to 2 years. The most frequently used SFRT for the curative intent was for head and neck, lung, and sarcoma. For palliative, it was for lymph nodes, metastasis, intra-abdominal sites, and lung. Integrating it with SFRT, integrating it with the systemic therapy, the curative system, they said like they were ready to put 45.5% with the concurrent SFRT, though most of them did not believe in putting concurrent chemo on the day of SFRT. They were keen to do it on the conventional, when we were planning for conventional external beam RT. Palliative setting also, they were considering systemic chemotherapy and immunotherapy, though very less percentage of them were doing it with the SFRT, 28.6%, but most of them who were doing it were believed that it could be done on the day of SFRT. So now, generally you will ask me, who are these practitioners and where do they where they are located? So this is a geographical location of the practitioners. Most of the data are coming from USA, while small from our Asian countries and other from the European and the Latin American. And we saw that the academic and the hybrid were also considering these practices. So with all this said and done, SFRT is increasingly being used in head and neck and lung sarcoma patients. We agree that there is a variation in the planning, dosing, and systemic therapy use. And what we can do is we can learn more, and then it will help us reinforce into the guidelines and education. With this, it's a shifting from uniform dose to the delivery to specially heterogeneous biologically guided radiation, especially in bulky diseases, and we need multidisciplinary teams to make a SFRT protocols. And with this, I understand that there is a lack of training and standardization to that can be gap can be corrected, and then we can just not rely on the anecdotal experiences but make our own things. Hence by SFRT isn't just a technique, it's a philosophy shift, and it represents how we balance protection and precision in modern oncology. And to fully realize its potential, we need data, discipline and multidisciplinary collaborations. With this, I want to say, like, we have a small data, and probably next time when we meet, we will have more mature data to say what happened to the patient. Thank you so much.
I'm going to talk about recent advances in HNSCC, newly published research. So area of discussion would be locally advanced, operable HNSCC, and second is high risk resected, which is stage 3 and 4 HNSCC. I thank MSD and BMS medical team for providing me the slide deck and published literature. So first I am talking about Keynote 689 trial. It was open randomized phase 3 study to see the efficacy and safety of neoadjuvant and adjuvant pembrolizumab with standard of care compared with standard of care in newly diagnosed and resectable locally advanced HNSCC. So this was the trial design. Eligibility criteria are adults, include the all subsites, larynx, hypopharynx, oral cavity, stage 3 and 4A. Oropharyngeal for P16 positive, it was T4, N0, N2, and P16 negative, stage 3 and 4A. Tumor tissue for PDL1 testing was required. Stratification was done on the basis of PDL1, tumor stage and primary tumor site. So for the standard arm versus neoadjuvant phase, there was 2 cycles of given pembrolizumab followed by surgery every 3 weekly, and then on the basis of histopathology report, standard of care consists of cisplatin with or without radiotherapy. In adjuvant, they give 3 cycles of pembrolizumab every 3 weekly followed by 12 cycles. So primary endpoint was EFS, and key secondary endpoints are measure pathological response by blinded independent review and OS. Other secondary endpoints are safety. These were the study treatment details. So baseline characteristics, median age is 60 years, 78% were male, 80% smokers. Alcohol use were also studied. Majority of the patients are oral cavity, which is 60% in both arm. And one more thing, PDL1 CPS is more than or equal to 1 in 95% of the patients. So we can say all of them are majority PDL1 positive patients. 88% patients underwent surgery, and adjuvant therapy received by at least those who received more than or equal to 1 dose of adjuvant therapy, 74%. Durations of treatment, so cisplatin was received in majority, median cycles were 3 in both arm, and in pembrolizumab out of 17 median cycles received were 15. This is the primary endpoint, which was studied first in the CPS more than or equal to 10 population. At 3 years, difference was from 46% to 60% with hazard ratio of 0.66, p-value was significant. Then it was studied into the CPS more than or equal to 1, again it was statistically significant, hazard ratio 0.70, and then in all participants also hazard ratio was 0.73, which is statistically significant. This was for subgroup analysis. It also majorly helps in the younger patients less than 65 years of age, and for PDL1 TPS either less than 50% or more than 50%, it helps. So major pathological response rate increased from 0% to 13.7%, and CPS more than or equal to 10 population, and in CPS more than 1, it increased from 0 to 10%. So basically 10% we gain major pathological response. Key secondary point OS for CPS more than or equal to 10, hazard ratio was 0.72, p-value was significant at 3 years from 60 to 68%, and then common treatment related adverse events, definitely it's marginally higher for especially dermatitis, stomatitis, and immune mediated adverse events were hypothyroidism, pneumonitis, and skin reactions. So to summarize, neoadjuvant and adjuvant pembrolizumab added to standard of care significantly improve EFS in resectable locally advanced HNSCC in all 3 pre-specified analyses, CPS more than 10, CPS more than 1, and all participants. Now my take is here majority of the patients are PD-L1 CPS positive, and some of the data supports that in head and neck around 80% patients are PD-L1 CPS positive. So at least for stage 3 and 4 resectable in a MDT discussions, those who are having a bad biology should be discussed this option. Second trial is recently presented in a plenary sessions at ASCO 25, and it is NEO post-op trial, GORTEC 2018-01. This is presented in a ASCO 25 this year. It was a randomized control open label study, 680 patients studied. Eligibility criteria are age more than 18 years or less than or equal to 75 years. High risk is defined as margin positive extracapsular extensions, multiple nodes, and PNI at more than 1 places. The exclusion criteria is as mentioned in the slide. Now this was the study design. After surgical resections, depending on high risk features, stage 3 and 4, they are randomized 1:1. One is the standard arm, which is cisplatin every 3 weekly 100 milligram per meter square with radiotherapy 60 to 66 gray, versus nivolumab 240 milligram, and then after 2 week, that was first dose, after 2 week 360 milligram every 3 weekly with standard of care, which is cisplatin with radiotherapy. After completion of CTRT, 6 doses 480 milligram every 4 weekly. And these are the baseline characteristics. 75% were male, 54% are current smoker, 33% former smoker. And again in this study, PD-L1 CPS more than not available in around 5% of the patients, and they were positive in at least 85%, more than 85% of the patients. So this is a treatment exposure. Median number of nivolumab cycles are 10, and those who received radiotherapy within a defined time frame is 95% of the patients. 3 cycles cisplatin is received by around 62% of the patients, and cumulative dose received more than 200 milligram per meter square in either arm is comparable. This was the EFS data presented at ASCO. At 3 years, DFS was 63.1% with nivolumab to CRT, which is 52%. So 9% of benefit, delta is 9% with hazard ratio of 0.76, which is statistically significant, 24% reduction in the event-free survival, and this is subgroup analysis. Definitely this is not predefined, and we don't have a full publication yet. OS, as the data cut of the predefined events are not happened, so they couldn't study the OS, but yes, OS is in trend of positive trend, and treatment related adverse events are marginally high, especially grade 3. So conclusion is nivolumab in addition to standard adjuvant therapy improves the disease-free survival, especially in high risk resected locally advanced head and neck squamous cell carcinoma. So for me, again, a takeaway from this study is those who are definitely having a bad biology after surgery, multiple nodes, external extensions, T4 disease, should be discussed these options, because in like last 2 decades, this is the space where the standard of care has not improved. And in last 2 decades, this is the trial where we have a EFS data, OS data is not yet mature. At 3 year we have a 9% improvement in the EFS. Thank you.